So we're very excited to have Dr. Naomi Aronson here today with us. She is a Uniformed Services University of the Health Sciences Professor of Medicine with secondary appointments in emerging infectious diseases, pharmacology, and preventative medicine biostats. She's director of the USU Infectious Diseases Division since 2000. For a decade, she was director of the Leishmaniasis Center of Excellence at Walter Reed Army Medical Center, caring for hundreds of Leishmaniasis patients. She serves as the clinical consultant to the Department of Defense Leishmaniasis Diagnostic Laboratory, Walter Reed Institute of Research. She was chair of the IDSA/ASTMH Leishmaniasis Guidelines Committee that prepared the first North American clinical guidelines for the diagnosis and treatment of Leishmaniasis. She's a member of the NIH CDC Committee on Guidelines for the Prevention and Treatment of Opportunistic Infections in Adults and Adolescents with HIV, which is the global medicine section. And she's an editor of the textbook Hunter's Tropical Medicine and Emerging Infectious Diseases. She's also written multiple chapters and articles on leishmaniasis and conducts both clinical and lab-based research on translational topics related to cutaneous and visceral leishmaniasis, which is what we're talking about today, visceral leishmaniasis. So thank you so much, Dr. Aronson, for coming and joining us today to talk about this very important topic. And as a reminder to everybody, please just put your questions in the chat, and then we'll read them and address them at the end. And with that, I'll let Dr. Aronson take it away.
All right. Well, thank you very much, Dr. O'Connell, for inviting me to speak. For those of you who are in attendance, I'm truly in awe with this beautiful day out here, income taxes due, and holiday weekend upcoming. So you must really want to hear about this topic. So visceral leishmaniasis, from the perspective of a North American physician, if you look on the background here, you'll see the flagellated parasite. This is the form that you see in the insect vector, which is the sandfly, or you can see in my laboratory when we grow it. The slides don't seem to be advancing. Oh,
there you go. Okay, great.
So in general, leishmaniasis is one of these neglected tropical diseases. I think it's confusing to the uninitiated because it includes so many species, many different syndromes. And I think the key points are made in this infographic from the WHO that 1 billion people live in areas of the world which could be at risk for various types of infectious due to leishmaniasis. Visceral leishmaniasis, which is the topic today, has really had a true success story in the past decade of control in India, Bangladesh, and Nepal. But despite that, is grossly underestimated in terms of cases reported to the WHO. So I think currently they estimate 100,000 reported cases, and probably that's at least tenfold more than that exist. And remember that it's actually one of the parasites that kills. So behind malaria and Chagas disease, visceral leishmaniasis is the #3 parasitic killer globally. Some type of leishmaniasis is endemic to 98 countries, including the United States. And as I said, over 1 million cases have been reported in the last 5 years. There's a lot more cutaneous leishmaniasis reported than there is of visceral leash. So in the human, the parasite that causes visceral leishmaniasis lives inside your macrophages chronically and persistently, maybe for life. And what always intrigues me here is that, this is already a pretty inhospitable environment for a parasite to live within, but it lives within the phagolysosome of the macrophage. So, just really where it shouldn't be able to survive. And it's developed all kinds of interesting ways to stay chronic and persistent. And so when I think about another disease that sort of has the same kind of paradigm, it'll be a bit like tuberculosis. Now, this is a slide that sort of shows you the spectrum of the leishmaniases. There's a very sort of strict ecology of the vector, which are sandflies, the reservoir host, which is often an animal, and then the particular parasite. Today, we're only going to talk to the right of the screen about visceral leishmaniasis, which comes kind of in the zoonotic flavor. This will be most commonly the type you're going to see in the United States, Leishmania infantum, endemic to parts of all around the Mediterranean, parts of Europe, and Brazil particularly, as well as other parts of Central America. In contrast to that, there's anthroponic visceral leishmaniasis, where humans are the reservoir host. And this is really primarily centered around India, Bangladesh, Nepal, and Eastern Africa, such as Eritrea, Ethiopia, Somalia, and the Sudan. And so the reservoirs that are applicable to Leishmania infantum are cats and dogs. And there are many sandflies, which is the point of this long list, but they're very specific which sandfly would, in a certain geographic area, would be transmitting visceral leishmaniasis. So this is the most recent WHO map of where in the world you can catch visceral leishmaniasis. And the very dark brown areas are the highest number of new cases in 2019. And so you can see Brazil, East Africa, and India are the really hot spots currently. And so these two areas here in the old world are Leishmania donovani. We used to call it Leishmania chagasii in South America, but genomically we know it's the same as infantum. So to keep you up to date, we now call Leishmania infantum the parasite that we find in the New World. And you can see there's some endemic areas up through Central America. And then even though it's gray on this map, it's widely known to be endemic throughout the Mediterranean. And it was also endemic for areas where our forces served in Iraq and Afghanistan. Oh, I wanted to go back and just point out there's a new player in the block in Southeast Asia. While there were no cases reported in 2019, there have been case series reported primarily from Thailand. And also I wanted to point out that China is an area that's seeing recrudescent visceral leishmaniasis. So when I think about the risk factors for leishmaniasis, I think the primary one we'll all consider is, have you traveled outside the United States? And here the point is that while for cutaneous leishmaniasis, it's probably appropriate to restrict that to fairly recently, for visceral leishmaniasis, being it's chronic, it's persistent, it can reactivate much later in life, I really ask that lifelong. And I also remember that it can be congenitally transmitted, so you can ask about the mother's travel history. Now it's becoming more apparent that there's a high degree of infection. Well, there's a significant degree of infection in companion pets in the United States. This has really been mostly the work of Christine Peterson in hunting dogs, but I think her recent publication suggested 3% of dogs in the US are chronically infected with visceral leishman. You should perhaps remember, certainly for us in the military, our military working dogs are frequently bred in Europe and then imported into the United States, and have suffered congenital transmission in Europe. And then don't forget that blood transfusion and tissue transplant are also ways to acquire visceral leishmaniasis. And so the tricky thing about VL is that you really have to think about it as a chronic persistent infection. These factors are reasonable to ask lifelong, even if travel was remote. And so just a little bit about visceral leishmaniasis, because I promised most of my talk is to go over some cases that I wanted to share with you. But now I think it's well accepted there are 3 species, L. donovani, L. infantum, and we used to call this also Leishmania chagasii. And now there's a new one called Leishmania mundinia martinicensis, which has really been around for 100 years, but we've sort of been watching these. We used to call them the Leishmania enretii complex, but now in the last few years, it's been accepted that it's a subgenus Mundinia, and the visceral form is most commonly seen in Thailand, and it's seen in both normal hosts and in immunocompromised hosts, primarily HIV-infected individuals. This slide from the Armed Forces Institute of Pathology really makes the point of the significant organomegaly you see with this infection, the huge spleen you see in this patient, but really the thing to note here is the hemorrhage that's seen in the lower pelvis. And worldwide, people diagnose visceral leishmaniasis by puncturing the spleen, and they accept what is a published rate of death from the procedure of 1 to 100. 1 out of 100 people succumb to the bleeding after splenic puncture in patients who are commonly very thrombocytopenic. So we don't use that approach so much in North America, but I think this autopsy photo makes 2 cases there. The incubation period for primary infection is weeks to months, but of course, since it can reactivate lifelong, it could activate much later than it was acquired. And death is usually due to the complications of hemorrhage from significant thrombocytopenia, or due to secondary bacterial viral infections because of the neutropenia that's seen. So those are generally what causes the cause of death. And I think it's important, though, to weigh this with the fact that we now know most infections are inapparent and self-resolving, although some will have some mild sort of smoldering symptoms. There's a recent scoping review out of BMC that was just published suggesting they found 3,008 articles on the syndrome of asymptomatic visceral leishmaniasis. So it's a very hot topic in the field, but I think it doesn't surprise you that as an infectious disease controlled by the immune system, there can be a whole spectrum of disease. And we really generally only identify the ones that have this pentad of Kala-Azar, which is sort of symptomatic visceral leishmaniasis, as shown in these two Kenyan children, with a photo of Dr. Oster's, where he's drawn how huge the spleen is in these children, but they're very wasted, as you can see by how you could count each of their ribs and their very thin extremities. So Kala-Azar is a febrile illness associated with a lot of wasting because of TNF-alpha and IL-2 secretion by the infected macrophages. Really profound splenomegaly, one of the biggest spleens that you'll see in infectious disease. Pancytopenia is commonly seen, and the bone marrow is often infiltrated. And then there's a polyclonal gammopathy that's often associated with Kala-Azar. Now, this is an important infection to recognize and treat because you can already figure out that the diagnosis won't be made in your usual clinical laboratory. It's 95% fatal without treatment. And even with treatment, particularly when treatment started late, can still have a 6 to 8% fatality. So it's a very serious infection, as mentioned, the third leading parasite killer globally. The leading risk factor in the world is unfortunately malnutrition. Then just quickly, the diagnosis, basically you have to get tissue. I don't advise splenic aspirate, although that would be a very sensitive place to find the parasite. You're looking for the rounded up amastogote form in tissue, often described as the dot dash, if you like Morse code, where the kinetoplast is the rod-shaped dash and the larger structure is the nucleus. Inside each one of these is an amastogote inside a macrophage. So in the US, I would probably start out with the lower sensitivity of the bone marrow because it's safe. And that's probably the initial tissue sample I'd advise. But you can also find it in liver and lymph nodes. So those are other sources to perhaps biopsy. And then if you have a very immunocompromised patient, particularly AIDS patients, you can find it in the blood, so in the buffy coat, or in the peripheral PBMCs. And then what do you do with those tissues? Dr. Wertman's on the call. He actually developed a very nice Leishmania PCR, which we still use in our laboratory, which was cleared by the FDA. It's called the Walter Reed, well, it's called the Smart Leash PCR, I think. People are moving into targeted genome sequencing. Specialized laboratories can offer you Leishmania culture. I regret to tell you that the CDC's lab has been offline since September and not quite ready to come back online. So I would advise, if you're looking for an alternative place to get diagnostics for Leishmania, that the University of Washington has been providing that for people in the interim. And if you have a veteran or someone who's acquired it during DoD service, please contact me. We'd be happy to do it in the military Leishmania laboratory. Otherwise, there is a role for serology. Unlike cutaneous leishmaniasis, there is a role in visceral leishmaniasis. The FDA has cleared the, if you will, dipstick RK39 assay, which is very sensitive in symptomatic disease, not quite as sensitive in East African visceral leishmaniasis, and so that's an area of current investigation. But it's a very good. I would use it as a screening test. Personally don't think that it suffices for a diagnosis, but it certainly make you look a little harder. And so just in summary, these dipsticks, are just a bit like the Binax. You can see this is the positive one, the second from the left with the second band that you see here. Uses serum, is very quick, is cleared by the FDA and very sensitive, except in East African visceral leishmaniasis. In East African, it still has a sensitivity of over 80%. what are the treatments? Unlike cutaneous leishmaniasis, which has all kinds of nooks and crannies and caveats, visceral leishmaniasis in North America is almost always, unless it's someone who's come from an endemic country where there's Donovani, it's almost always Leishmania infantum. And because of that, the drug of choice is FDA approved, and it's ambisome, and is a total dose of 30 milligram per kilogram. And you should just know that higher doses are required for immunocompromised individuals. If you had a patient with visceral leishmaniasis from East Africa specifically, there has been some trials with lesser efficacy of ambisome. And so the leading WHO recommendation for treatment in East African L. donovani is actually a combination of pentavalent antimonial drugs, such as pentastam or glucantine, and promomycin, which we don't have parenterally in the US. And indeed, currently pentavalent antimonial drugs are not available in the United States. Multefacin only approved for Indian Leishmania donovani, and for whatever reason, the L. donovani in India is very sensitive to both liposomal amphotericin, so they actually get away with a single high dose, 10 milligram per kilogram, or they can use multefacin, but it is not as effective for Leishmania infantum. So you just know that miltefosine is FDA approved and it's oral. That's most of the point I wanted to make from this slide, but only use it for Indian L. donovani. In pentavalent antimonial drugs, unfortunately, Glaxo stopped making pentastam 2 years ago, and we no longer have a supply in the United States. It had been showing some increasing resistance, particularly in India and South America. So there had already been a pivot towards liposomal amphotericin, but it's still used in much of the world. And I suspect the FDA, CDC predicts maybe it will take 3 years, but they will get glucantine in the United States. So in the future, we'll have it as a backup therapy or a therapy for patients from East Africa that fail lipo and B. All right, so that's to bring us all up to sort of the same understanding of this infection. And now what I wanted to use my time here for is a couple instructive cases. And since my practice is in the military, all of these cases have come to me through that conduit, which may be a little bit different than perhaps your experiences in major cities in the United States that see global medicine. But this is a 20-year-old Army male who's been assigned in Baghdad for 11 months. He comes in the spring with fever, sweats, and chills of an acute onset, and is basically assessed to have an acute viral syndrome, and no diagnostics are done at that time. But when he has hematemesis 2 weeks later, and then he reports he's also having diarrhea, and the fevers are continuing, he's found to be pancytopenic, and he has elevated transaminases. He's put on an aircraft and sent back to Walter Reed. So about a month of illness now, still having daily fevers, often up to 104. He's lost more than 20 pounds. He's got some nonspecific symptoms, but he also has what he describes as rigors and a productive cough. He was a very healthy young male. He was on no medications. He was a tobacco user. He was a security escort to VIPs in the green zone, so he never had missions at night. He slept inside in one of the palaces. He ate in the military dining hall. He only drank water from bottled water. He had no ill contacts. And so, of course, the thought at this point was that we were dealing with a malignancy, perhaps a leukemia lymphoma. And so he was here in Washington, and we were assessing him. And the first thing that I was really impressed by is he was relatively well appearing for someone who'd had a month of fever and 20-pound weight loss. He was very comfortable in bed. He was afebrile when we first saw him, although he did have temperature elevations every day. His physical exam was only remarkable for a palpable spleen about 5 centimeters below the left lower rib. You can see his transfer labs. He has pancytopenia, pretty profound. He has very mild elevation of his liver-associated enzymes, low albumin. He was HIV negative. Because of his cough, he had a normal chest X-ray. And if we drill down, the hematologist reviewed his peripheral smear due to his pancytopenia, and really it was pretty nonspecific, as you can see here, no signs that were concerning for malignancy. He had malaria smears, he had blood cultures ×3 at Brucella serology. and to look for other sources of adenopathy, and this hepatomegaly. A CT scan of the abdomen was done, and it merely showed what we found on physical exam was splenomegaly, and the spleen was completely homogeneous. He did have the serology done. He had an RK39 serology done, and it was found to be positive. So because of his, most concerning diagnosis at the time, he had a bone marrow biopsy, and I'll just show you here on the right. The A mastocytes are clustered there, usually seen fairly easily just with H&E staining. But we also grew them out in culture, and this is when you see the flagellated, in the laboratory, the flagellated promastogote form. And we were able to identify this patient was infected with Leishmania infantum from Iraq. So we reported on like the first 5 patients we saw at Walter Reed back some time ago now. They came from, these are symptomatic visceral leishmaniasis patients. We went on to count 25 between Iraq and Afghanistan in the last 2 decades. So we certainly know that both theaters provided symptomatic illness. In these 5, they were all within a year of leaving the country, but I will submit that you can have it later than that. It can reactivate. And they got it both in Afghanistan and Iraq. They all had these classic symptoms of cytopenias, fever, weight loss, elevated liver function tests. And the weight loss, you can see, could be up to 37 pounds in one situation. The diagnosis was made on tissue, usually bone marrow, but both the cases from Afghanistan were interesting in that the bone marrow was negative. Because the RK39 was positive, the syndrome was so consistent. We biopsied the liver, and in both cases, the liver had this very granulomatous hepatitis, but it was found to have mastocytes as well. And PCR was a good way to make the diagnosis. In some cases, we could actually culture it as well. These parasites that are associated with visceral leishmaniasis are a little harder to grow than the ones that, in our experience, than the ones that cause cutaneous disease. And then they all responded nicely to ambisome, but another teaching point on this slide is that the one patient who got lipid complex, ABLC, failed therapy. And this is not unique to our experience. When I've talked to other people who treat this, they've had the same experience. So please use ambisome specifically, which is the FDA approved drug for this indication. And other amphotericin compounds may not work quite as well. So what I just presented to you is just a very typical case of visceral leishmaniasis in a fairly healthy young man. And that was sort of just to give you a sense of how most of our cases present. But I've already alluded to the fact that this is just the tip of the iceberg when you see symptomatic Kala-Azar like visceral leishmaniasis. And we certainly knew that we had a lot of less symptomatic, or maybe even asymptomatic visceral leishmaniasis that we hadn't identified. So this led to some further investigations I'll share with you in a minute. But this slide just reminds me to sort of give you, I think, a very nice figure of why does this happen. And so one, starts at the very beginning. If you're a normal host, partly it might be the amount of dose that you get. If you can overwhelm the typical immune response, which is your dendritic cells making IL-12, it stimulates T cells to make this very nice granuloma that contains the parasite through interferon gamma secretion, triggers reactive oxygen species and nitric oxide to kill the parasite inside the granuloma. And this would be, if you're going to be infected, a good immune response versus a variety of things that can tilt it more towards an IL-10 driven regulatory response, where you may have a more symptomatic syndrome. So things like malnutrition being the most common worldwide, but biologics, particularly TNF-alpha inhibitors, other reasons to have a Th2 response to the parasite. And then clearly we know from Europe, HIV, specifically AIDS, with very low CD4 count, was one of the most common opportunistic infections before antiretrovirals were active in Europe. So as I said, since we had the tip of the iceberg kind of phenomenon, we wanted to look in the military and see how often we had asymptomatic visceral leishmaniasis, and I wanted to briefly share with you some of our surveillance results. So we knew from the CDC in Iraq that they had pretty much defined the areas in red and orange as where it was endemic in Iraq. And I had previously a map that showed our forces were well arrayed in these areas, Kuwait being down here. We knew the vector was phlebotomist alexandriae, and we knew that most healthy adults will have no symptoms. But this is the case rate for symptomatic Iraq nationals, it's almost 5 per 100,000. So we enrolled 200 healthy participants who deployed to Iraq. On average, they were about 10 years since their deployment when we enrolled them, and we did blood testing that I'll describe in a minute in a risk questionnaire. And then we have this lovely resource in the Department of Defense where we keep leftover serum from everyone's HIV tests that's on active duty in a repository over in Silver Spring, so we can ask back in time for samples of serum closer to deployment. And so the testing that we did in my laboratory included the standard of care RK39 dipstick. We measured the human immune response to the saliva of the vector, Phlebotomys alexandriae. And then we developed some research tests to include a quantitative PCR that we did on the PBMCs, an interferon gamma test, much like a TB quantiferon test, but for Leishmania. And then we measured the serologic responses immediately with their post-deployment sera and as well as now. And the first thing I'll just share with you is that the RK39 in an asymptomatic cohort, this has been well recognized in phantom cohorts in Brazil and Spain, is not a good test. It's not sensitive in this situation without symptoms. So I wouldn't use it for an asymptomatic person. We had one subject whose sera was positive on his return from deployment. While his ELISA test was positive both points, he lost his RK39 in the follow-up serology. So I think the take home is RK39 is not so good for polysymptomatic or asymptomatic visceral leishmaniasis. And then, as I just mentioned, the serum closer in time had a rate of about 13.5% positive versus the serum now, which was about 10 years since deployment, was at 5%. So if you want to look at serology in an asymptomatic individual, you want to have it closer in time to the likely exposure. What we did find that extends the knowledge, and Iraq now agrees, that the place most of our soldiers got infected was up in Nineveh near Tal Afar and Mosul, where we also had a fair amount of cutaneous leishmaniasis. So they now agree that we can extend their map up to the Syrian border, and so this area was particularly problematic for our military in this study. So if you're interested in this topic, we did publish our results in Clinical Infectious Disease in 2019. We found 2 persons that had a quantitative PCR positive for Leishmania in their blood. Interestingly, although they seemed healthy on enrollment, one had had a traumatic splenectomy and the other was found through Dr. Steve Holland's immunobiome study to have a STAT3 deficiency. So there might have actually been some inherent checking on not, your idea that it's relatively unusual for a healthy person to be having antigen circulating in their blood, but it certainly has been described in global experiences around the world. And then 14.5% were positive on our interferon gamma release assay. So I think this experience, to me, raises some additional questions about what is the risk lifelong for this population of between 1.5 to 2 million persons that went to either Iraq or Afghanistan in terms of reactivation risk, particularly as they may develop other conditions later in life and be very long time since they were in an endemic area. And so the diagnosis may not be considered seriously at that point. And then you think about the paradigm of HIV and what does it mean to have a chronic inflammatory state with a parasite living inside your macrophages lifelong? And will we see the premature aging? Will we see the complications that we're starting to identify in chronic HIV infection in this population, such as accelerated cardiovascular disease, dementia, renal disease? And then lastly, did we cause any risk to the US blood supply? This again is a white blood cell associated infection. And while it's certainly been reported to be associated with transfusion risk, the DoD system, over 70% of the cases of blood given are usually with white blood cell filters. And so we haven't had any transfusion cases that have been identified as visceral leishmaniasis in our system. So then if we move on to another case, I want to talk to you about a National Guardsman. This is just to give those of you who are not in the military a sense of, this was a unit, an aviation unit in Iraq that one of the patients I had gave me a picture of, just to give you a sense how close to nature and sandflies our military lives when they deploy in some situations. So this study really starts more than 10 years ago. And this National Guardsman lives in Tennessee, in a river valley in Tennessee. He's actually being seen in the Memphis VA. At this point, he has tongue swelling and now a very painful dorsal tongue ulcer for the past 2 weeks, quite large, 3 centimeters. His recent travel has only been within the United States. He did deploy to Saudi Arabia in 1991, and 6 years previously, he deployed to Iraq. This is his past medical history in 2009. And his past medical history is remarkable because a year after he returned from Iraq, he had a liver biopsy done for elevated liver function tests and splenomegaly. He also was having night sweats, but no fever. And he'd had some weight loss, and you can see his alkaline phosphatase was quite elevated. That biopsy was non-diagnostic. It showed non-necrotizing granulomas, and no specific diagnosis was reached. And then while he's presenting with his tongue ulcer in 2009, prior to that presentation, he had had a bone marrow biopsy to evaluate his chronic thrombocytopenia. And that has shown, again, non-necrotizing granulomas, no specific diagnosis made. So this is the tongue ulcer. It's pretty dramatic. He's chronically ill. He's lost a fair amount of weight. He has oral candidiasis, but no generalized adenopathy. There's no splenomegaly or hepatomegaly at this time, and no skin lesions. And here are his regular laboratories in 2009 when he presents with the tongue ulcer. Again, he has pretty elevated alkaline phosphatase and transaminases. He had a non-calcified pulmonary nodule in his right upper lobe, and his CT showed splenic lesions that were consistent with granulomatous diseases. So his clinical course is that his tongue lesion continued to enlarge. He had a couple of biopsies that were non-diagnostic, and eventually it was such a problem that they did a partial glossectomy and primary closure. And this tissue showed extensive granulomatous inflammation, and this time some intracellular microorganisms were seen. And this was the histopath finding. This is described as a Giemsa stain, reviewed under medium power. This did not lead to a specific diagnosis. So additional testing included that he remained HIV negative, RPR non-reactive, tuberculin skin test non-reactive, CD4 count almost 500, ACE normal, immunoglobulin levels normal. And his physician actually had served at Walter Reed previously. I went down to the lab and asked if they could look at the biopsy, the tongue biopsy again under oil immersion. And lo and behold, they saw these intracellular organisms that you can see right here, the nucleus and the kinetoplast here, that are diagnostic of amastigotes. So serum RK39 was done after seeing that, confirmed positive. The biopsy tissue was sent to the Walter Reed laboratory and was PCR positive for Leishmania, but the parasite culture was negative. And AFB cultures, fungal cultures, very special stains, they were all negative as well. So he was treated with liposomal amphotericin, 30 milligram per kilogram, the usual dose, but the dosing interval is usually boosting at day 14 and 21. And his symptoms resolved. He gained 10 pounds, his laboratories normalized, and his tongue ulcer healed. In this case, if you wanted to read more about it, it has been published previously. Okay, but that's not the whole story. So 1 year later, he comes back, the tongue lesion has relapsed. It's rebiopsied, it's PCR positive. Again, we can't culture the parasite from it. Granulomas are seen. He's given another course of liposomal amphotericin, and he does okay for 5 years, and he comes back with a recurrent tongue lesion. And now he has a lesion on the skin at the tip of his nose. And the tongue biopsy confirms Leishmania, PCR positive, amastocytosis positive. The nasal skin just was described as granulomatous dermatitis. They favored rosacea versus sarcoid. No organisms were seen, so it wasn't sent any further for Leishmania diagnostic. And he was treated with liposomal amphotericin, and he improved. So I came to know of this case directly in last summer when he came back to clinic, and he was having tingling in his tongue, although the ulcer had not recurred. He said this is always how it starts. And the lesion on his nose had just continually gotten more infiltrative over the 5 years. And now he had a genital lesion that was an infiltrative plaque. He had a mucosal exam, and on ENT exam, no mucosal lesions were seen. The skin was biopsied and again showed granulomatous dermatitis. So you can see this is not the most dramatic lesion you've ever seen. This dark area is actually his suture site. And so this infiltrative erythematous area on his nose is what has been there chronically for 5 years now. So he went through his usual workup. The CT of chest, abdomen, pelvis was normal, essentially. He was not pancytopenic. His thrombocytopenia remained. This time his liver tests were pretty good for him. Alkaline phosphatase was a little bit high still. His CD4 count was still robust at 893. His HIV is still negative. TB test was done, it was negative. Fungal serologies were done, they were negative. The skin biopsy was special stains, was looked at specifically for Leishmania.
Hey, Teddy.
Hi, Mama.
And,
How you doing, boy?
Somebody's got a hot mic, please. Could turn it. And so they sent it, they talked to me at that point about it, and I said, well, could we look at it in our laboratory? And we had our Joint Pathology Center review it, and they did see amastogotes on it. Also was PCR positive, and again, we could not culture parasites from this PCR positive sample. So we sent it for sequencing the CDC. Now we know what organism it is. It's Leishmania infantum. The PCR can't tell whether it's Donovani infantum, and indeed, it's often in the US with the isoenzymes we use, hard to separate out the two. But with the Iraq exposure, it's going to be Leishmania infantum. So what syndrome does this patient have? And I think very clearly this patient has visceral leishmaniasis, which he presented with within a year of coming back from Iraq when his granulomas were seen in the liver. Unfortunately, they no longer have that histopath, so we can't prove that to you, but I think that's when it started. And then his bone marrow has the granulomas in it. He has tongue ulcer with Leishmania in it, and now he has skin with Leishmania in it. And a very chronic and relapsing case, responding to liposomal amphotericin for a couple of years and then recurring. So really a management problem. So I don't know exactly why he's not responding to liposomal amphotericin. Generally, Leishmania infantum is not that resistant to liposomal amphotericin from Iraq. I think that he seemed to get better with each treatment course, which also weighs against that. I sort of favored he must have an unrecognized immunologic defect that doesn't really allow him to completely control the parasite. But maybe it's just that he hasn't gotten enough, because for mucosal leishmaniasis, we tend to use quite a bit more liposomal amphotericin B. And there's a case reported of a tongue ulcer from Croatia that was Leishmania infantum, where they had to be treated twice. So, maybe it's not enough. Maybe he doesn't have the immune control, less likely to be drug resistant. So this was what I recommended to the team. I can tell you that the immunobiome assessment by Dr. Holland was actually nothing abnormal was identified. We gave him the immunocompromised visceral leishmaniasis dosing of 40 milligram per kilogram. And then I proposed that maybe this was a candidate given how many relapses he's had for secondary monthly prophylaxis with a single dose of lipo-AmpB monthly. So I think the key points of this case are, please consider visceral leishmaniasis in Iraq-deployed veterans for years. And it's a chronic persistent infection. The second teaching point is that I wasn't aware, but pathologists don't typically, if they don't see anything on their screen at 40x, they don't typically look at things with 100x oil immersion like we do in ID. So certainly if you have a concern, ask them to, if they could look a little bit harder. And again, it's something that is just not familiar as an organism to many US trained pathologists. And then the other teaching point is mucosal leishmania infantum usually suggests an immunocompromised host, but obviously not always. This is a presentation you might see in an HIV patient, for example. Higher doses for immunocompromised patients and for mucosal disease. And then the last point is that she asked me about, Dr. Eason asked me about miltefosine, and it's less active against Leishmania infantum than Donabani. So since he seemed to be responding to lipo-AmpB, we gave him higher dose, and so far he's doing okay. So I thought that was a pretty instructive case. Now I see my time is vanishing. I want to move on to Sicily and tell you about a youngster, 7.5-month-old male who's having temperatures to 104 for a month. And you can see pretty nonspecific symptoms of diarrhea, non-productive cough, tried trimethoprim and cefepime, made no effect on the fever, and is transferred from his home in Sicily, where he's living with his Navy parents, to Walter Reed, obviously for concern for malignancy. And here's his physical exam. He wasn't particularly toxic appearing. He was fully ambulatory, but he had a temperature of 104. He had a pretty enlarged liver and spleen. You probably saw on the last page slide that we had drawn out how large his liver and spleen were. And he had a laboratory evaluation with hemoglobin of 7.6, platelets of 78,000, triglycerides of 660, and elevated alpha phosphatase and AST and ALT. Also had an elevated ferritin level. Had a normal chest X-ray despite his cough. And he had a bone marrow biopsy. And this is what they saw on the bone marrow biopsy, which, you know, when you see red blood cells being engulfed by white blood cells is never a good thing. So, you know, obviously we ask, well, what syndrome does this patient have? And the answer is he has HLH, clearly, by the diagnostic guidelines, with his fever for a month, splenomegaly, anemia, thrombocytopenia, high triglycerides, and bone marrow with hemophagocytosis. So these are the old days, and we treated him with pentavalent antimonial sodium stibogluconate, and he had a very quick response of his temperature, and then eventually his cytopenias, and then his splenomegaly after treatment. So the teaching point here is he had HLH, but it's due to visceral leishmaniasis, and he should have his visceral leishmaniasis treated. That's the first approach. This is well known. It's mostly seen in older adults and young children. And you know, there's no difference. It's caused by basically dysfunctional activation of T cells, NK cells, and macrophages from this chronic antigenic stimulation. It's usually seen in people who've had their illness for longer periods of time. And the cytokines Th1 and 2 and 17 are much higher in VL-HLH than just VL, with the one exception that IL-10 is lower if you have HLH than in VL. And the NK cell activity is very reduced with HLH. So again, teaching point is treat the visceral leishmaniasis, not the HLH, and it often resolves. There was a very February 2022 series from Beijing, China, of investigating HLH versus VL patients, and besides a very nice picture they have of their hemophagocytosis with the parasites also in the macrophage, they did a very nice profiling of the cytokines and what happens if you want to see details of that. But something novel in this paper was that they looked at liver iron load and showed it was much higher in those with HLH versus VL alone. And then they did PET CT and showed that there's no lesions per se, but it's very hyperstimulated in the liver and the spleen associated with HLH as compared to visceral leishmaniasis alone. So my last case, I want to take you to the Gold Coast of Spain, a lovely place that people go for a vacation. This is a 46-year-old law professor at Georgetown who has a 5-year history of HIV, is known to have a CD4 count less than 50, has already had one opportunistic infection of CMV retinitis. And in these days, the treatment of choice for him was stavudine and linezolid. So, this is really dating our HIV management. He's been back in the DC now for several months, and he has weeks of liquid small volume bowel movements, weight loss, and fever. In taking his travel history, he's extensively both lived and traveled in Europe, but none of it particularly recently, although 2 years previously he was in Italy along the Amalfi Coast, and again recently along the Mediterranean coast of Spain. He was intermittently febrile. He had a liver that percussed 23 centimeters, was pretty non-tender. He had a spleen tip that was just palpable, a centimeter below the costal margin, and he had generalized adenopathy. You can see his pancytopenia was profound. He had a CD4 count of 2, with a viral load of 77,000, an elevated alkaline phosphatase of 228. He had had stool culture, OMP, and cryptosporidia testing that were all negative, and he had had a screening because of his travel history, a serology, immunofluorescent antibody assay that was at the very lowest level of detection at 138. So his GI doctor in Washington did a duodenal biopsy, and this really revealed the answer quite quickly. This particular biopsy, all these clusters that you see here, these are all amastocytosis of Leishmania that's seen in the duodenal tissue. So it was probably not the diagnosis we was expecting to see, but we were able to culture this parasite in 2 days. So it was a very heavy infection, and identify it to be Leishmania infantum. So a couple things, serology is less helpful in HIV patients, so it can, particularly RK39 has been shown to sometimes be negative in patients with overwhelming visceral leishmaniasis in this population. But you can see a mastocytosis easily in tissue, and you can even see it in the peripheral blood in the buffy coat. Another thing is that HIV, AIDS, and visceral leishmaniasis, the presentations are atypical. They're common on the skin or in the mucosa. I've seen cases in the esophagus. You see this case here in the GI tract. And also I've seen a apple core-like lesion in the colon and a rectal mass. It can also cause pleuritis or pleural effusions. And so the other thing that's different is that splenomegaly is actually less prominent, whereas almost everybody else without HIV will have a huge spleen. In this population, often the liver is more enlarged, as is seen in this patient. You should know that pentavalent antimonial drugs are toxic in AIDS patients and poorly tolerated and have led to death. And in those that have low CD4 count, antiretrovirals should be started as a critical part of the management. But there has been iris seen with visceral leishmaniasis. It presents as Kala-Azar dermal leishmaniasis looking, or other skin lesions that look more like disseminated CL. So that's usually when you have iris, that's the presentation. You should know that you treat them with higher doses of liposomal amphotericin and longer. And just recently for Donavani VL HIV out of both Ethiopia and India, studies have suggested much better outcomes if you use combination therapy with miltefosine and lipoampho-B. And this is a scenario where secondary prophylaxis with monthly pentamidine or liposomal amphotericin should be used until immune reconstitution is seen over 200 for 12 months. So Jen, just to recap, the treatment of Leishmania infantum visceral leishmaniasis is liposomal amphotericin at higher doses than you'd use in a non-immunocompromised host. But Leishmania Donavani, you now have the option of using that which is also very reasonable. But now, at least the WHO is provisionally pivoting to recommending combination therapy. So the difference between using lipo-AmphoB and lipo and miltefosine in the HIV-VL Donavani is at about 85% cure in monotherapy, but you can bump that up to 96% with combination therapy. So I think that the field will probably move to recommending for Donavani specifically, the study's not been done in infantum, combination therapy. And this is just from the paper published 2 months ago, showing the difference between, in red, the combination therapy, and blue, the liposomal only. It also makes the point that people were treated for 30 days in this study and followed out primary endpoint 210. It makes the point that people will relapse without prophylaxis. So this population, you absolutely need to use secondary prophylaxis. And sometimes in Europe, they use the quantitative PCR blood, but we don't have anywhere in the United States that's doing that. So sometimes in the US, you just have to follow the patient to relapse symptomatically. And I think in summary, I hope you'll keep in mind the Cala-Azar syndrome of fever, splenomegaly, weight loss, and pancytopenia, because it's a fatal infection if you don't think of it and treat. But remember that most people are going to be asymptomatic or polysymptomatic and probably never identified, because there's no testing you can use in clinic aside from research testing to identify this. And the treatment of choice in the United States for Leishmania infantum is liposomal amphotericin. But if you have a patient from East Africa, say South Sudan, Ethiopia, you might want to consider, particularly if they don't respond well to lipo-AmphoB, obtaining pentavalent. Something like sodium cybogluconate or meglumine antimony. So that's what I presented. I hope some of those cases were of interest to you and perhaps some new points. And I'm happy to take your questions.
Thank you, Dr. Aronson. That was amazing. That was really, really quite instructive and very comprehensive. Excellent. So there's just a few questions, and people can feel free to continue to type in the chat as we talk. But I guess starting out, going back to the very beginning when you were talking about the epidemiology, there was a large amount of African countries that were grayed out, and there was a question about if there was any information of the existence of visceral leishmaniasis in any of those countries.
So this is just 2019 data from the WHO. They have earlier maps that do show some involvement in those areas. I'm blinking exactly on where they are, but certainly with control, visceral leishmaniasis changes around in its distribution. So I would consider Central Africa as low, but something to consider. You know, don't take it completely off the table.
And that would be
only go with the epidemiology such as it's reported. Not all countries report to WHO.
And that would be Donavani, I assume.
Yes, that's what. Right.
I had just while we're on the topic, a quick clarification question, because you mentioned a few times there referenced North American disease and people having dogs that companion pets that may be infected with visceral leishmaniasis. Have there been reported cases of acquisition of visceral leishmaniasis within the United States?
None that have been identified. What we know is Leucemia shannoni, a very permissive sandfly, has been proven to allow transmission from dog to dog in the United States. And also in the laboratory, they've shown that it can transmit to hamsters. So I suspect that if we had Leucemia shannoni that got infected, that it could infect people, but we've not identified that.
I see. And what area of the country would that be in?
Yeah, so shannoni is now in like 19 states. So aside from the far north, with global warming coming there soon next, I guess, but it's pretty much the southeast of the United States, the southwest of the United States, and It was measured as far up as Kansas, I think, in the north.
Okay. Okay, so we'll get through a few more here. And the case that you presented where the patient was actually on fluticasone and that was stopped I think that was the tongue lesion patient, if I remember correctly.
That's right.
Was there any thought or ability to get fluticasone levels? I guess the thought being, is there some sort of metabolism problem with potentially the steroids?
Oh, you mean sort of like what we see with ritonavir in our HIV patients? Well, we didn't
Sure.
consider doing that. I just suggested they stop using that.
Yeah.
As Dr.
So
Whitman knows
the-
well, putting a little topical steroids on top of leishmania is just like asking for it to grow. So it seemed like an
Definitely.
unnecessary thing to add to already problematic case.
So the reason for the question is that there have been very uncommon cases of, so there's a subset of people who develop systemic levels of fluticasone, and fluticasone is a very powerful steroid. And in fact, there was a report in the New England Journal of Medicine almost 20 years ago of invasive aspergillosis in someone who was on inhaled fluticasone. So, and we have recently seen a case of invasive aspergillosis also. So it may not be inconsequential, and actually it can be measured. And it's something to keep in mind. It's not only that instinctively makes sense, is that there are actually data and it's helpful.
Oh,
Sure.
thank you. That's good to know.
So what's your feeling about splenic aspirates for the diagnosis, giving its utility in visceral leishmaniasis in India? Thank you.
Well, my feeling is we shouldn't do it in the United States. I think that, it's a procedure that in experienced hands can be done fairly safely. But I mean, the statistics are published, and 1 out of 100 people dying of splenic hemorrhage is, that's a pretty high rate.
Yep.
So, you weigh whether you need to do that. You perhaps know that the DNDi is doing or planning even more treatment trials in India and other places, and they're going to try to validate the quantitative PCR to splenic burden, and perhaps have a less invasive peripheral study that'll be able to be used in the future. I think that'll mostly be useful in the HIV population, but my feeling is I wouldn't do splenic aspirates in the United States. I just feel like we've been able to find it in most other tissues. Just be persistent and try a few different places: bone marrow, liver,
Yep.
lymph nodes.
Okay, so the next question, and I might need Josh to weigh in and clarify, but the question, as I see it, is what does clinical or epi data show regarding prior cutaneous leash infection as being potentially protective against visceral leash? I think that's what he's asking.
Yes, well, so I know that Josh spent some time in the leishmania world over the Valenzuela lab, I think. But anyway, so there is, this continues to be a hypothesis that there's some immune response that can be used or has been suggested from previous, at least old world disease and visceral leash. I don't think there's any good data that I'm aware of new world like Braziliensis and infantum. And so this is always part of a discussion as you think about what kind of antigens to put into attenuated vaccines and things like that. But yeah, there's some epi that suggests there could be some level of protection against heterogeneous CL strains against visceral leishmaniasis.
Okay. And I guess we'll do one more, and then we'll wrap it up. In the patients who were found to have evidence of asymptomatic prior infection, what did you end up recommending if they need immunosuppression in the future?
Yeah, so that's a great question. We really wrangled with what to do with our population of patients that we found to be positive. We're currently doing a trial actually at Walter Reed right now of TNF-alpha solid organ transplant in HIV patients who previously deployed and are now have those conditions. So far, our PCR positive rate's about 8% in that population, but they, you know, we do have a very complete literature review to see if we missed infectious episodes that might have been in the past, and we haven't found that. So this is an area that actually we really need some data to know what to do. I guess from this limited experience, I think we've enrolled about 50 people so far. They've all tolerated their immunosuppression okay. And I don't know what percentage, besides the PCR, I think we calculated 20% of them had some test that was positive in some way, but we're still working out that data. The serologic data needs to have some Western blots done to really confirm that. So right now, what are we recommending? We're recommending that we not treat them before immunosuppression, that we follow very carefully, educate them on symptoms and their providers on the symptoms, because, you know, caught early, it's a very treatable infection. If you could give me an oral drug that had less toxicities and you didn't need to take for 3 weeks, I think, you know, you could rediscuss whether it would be the paradigm of TB, where, you know, latent infection for someone who's going to be immunosuppressed, maybe there would be some benefit to trying to treat. But right now, with the tools we have and the lack of information we have in knowing if there's any benefit, I would not treat people beforehand. I would just educate them and have them come in early for any symptoms that seem like activation.
Okay, great. Well, I think with that, we'll end here. Thank you so much for your time, and we'll try to get this up on our webpage soon so people can watch it if they missed it, particularly since we have a lot of people, I think, on spring break this week. But thank you so much. This has been great. And Dr. Aronson is always an excellent resource. It has been for us at NIH as well in terms of any clinical questions and difficult patients. So really appreciate you. And she's got her contact stuff there. Thank you so much.
All right, thank you.
All right. We'll see you later. Thank you. Thank you, everybody. Stop recording.